Hi, this is Dr. Bhargava. Here's the next video in the series Body Imaging Case Review. This is our first patient, and here the finding is in the right adrenal. We have a hypodensity seen in an enlarged adrenal, and this finding is seen right here. And whenever there is a tumor in the adrenal that measures fat attenuation, see how it's similar here in density to the intra-abdominal fat. The diagnosis here is a adrenal myelolipoma. They have additional findings too, such as this markedly enlarged spleen. This is our next patient, and here I'm trying to show you a finding that we incidentally see very frequently on the CTs of the abdomen and pelvis. It is seen as this metallic density with artifacts on the axial image, and this is how it's seen on the coronal image if you look at it in the bone windows. And like I always say, whenever you have something hyperdense, try to look at it on the scout image. So these are clips seen bilaterally in the superior aspect of the scrotums from prior vasectomies. So when you see them, just report that there are bilaterally vasectomy clips visualized. Here's our next patient, and we have performed a multiphasic CT of the abdomen to look at their kidneys. On the non-contrast enhanced scan, we find that the kidneys bilaterally are atrophic and they have multiple small cysts, suggesting acquired cystic disease of the kidneys. On the right side, there is a large mass that shows peripheral enhancement, and on the left side also there is a focus that shows enhancement. And so patients who have acquired cystic disease of the kidneys are predisposed to developing renal cell carcinomas. Here they have bilateral renal cell carcinomas, and a patient like this may undergo a bilateral nephrectomy before getting a renal transplant. This is our next patient. They had presented with dysphagia, and we had performed an esophagogram where we find on this image on the left a dilated esophagus layering contrast, and near the GE junction we see that there is severe narrowing in an appearance which is called a rat tail appearance, and these are some corresponding findings on their CT that was acquired without IV contrast, and these findings are characteristic of achalasia cardia. This is our next patient, and I'm showing you multiple images on this patient. The two images on the left are after their surgery, where there was a question of retained foreign body, and the plain films show a lap sponge in the right side of the abdomen, and we want to see this finding in two views to confirm that it's inside the abdomen or inside the patient. They also have other ureteric catheters and a percutaneous nephrostomy catheter, and the plain film on the right shows after surgery when the lap sponge was removed. So characteristic appearance of lap sponge on plain films, not to be missed on a post-op film from the OR to look for retained foreign bodies. Here is a patient who on this chest x-ray shows presence of a nail cutter that they had swallowed, and it is now residing in their proximal stomach. And so frequently we see plain films in patients who swallow foreign bodies or things that are not supposed to be swallowed. Generally, these are patients who are mentally deranged or have a psychiatric condition, and most of the times they are not symptomatic, or the foreign body does not cause bowel obstruction. And so the purpose of imaging is to identify the foreign body and over a period of time follow it through the bowel loop and make sure that it passes through their rectum in a few days. Here is our next patient. They presented with left-sided flank pain, and a CT of the abdomen and pelvis was performed with contrast. Here you can see that the right kidney is normal. The left kidney is abnormal. It shows hydronephrosis and hypoenhancement. There is some surrounding fat stranding also right here near the collecting system. And at the level of the urinary bladder, we see that at the UVJ on the left side, there is a punctate obstructing stone. And so the stone, also seen here on the coronal image, is causing upstream hydronephrosis and hydroureter. Because of that back pressure, there is not enough enhancement, and there is possibly some infection, although we don't see any signs of focal hypoenhancement in the kidney to definitely suggest signs of an acute pyelonephritis. So obstructing stone, hydronephrosis, and acute pyelonephritis cannot be ruled out. Here is our next patient, and I am showing you multiple images from their MR of the abdomen. We can see on this coronal T2 weighted image that both kidneys are markedly enlarged, and they are almost completely replaced by these T2 hyperintense cysts. And here's an axial image showing the right kidney, and here we have the left kidney. At the bottom we have two images showing DWI and ADC. And here there is a focus of restricted diffusion, so you want to raise a suspicion that there might be a renal cell carcinoma. This finding can also be seen when there is internal hemorrhage in one of those cysts, because blood can also restrict diffusion. All right, our next patient, here we have two ultrasound images. The one on the left is the long axis view at the level of the epididymal head, and we find that there are multiple tubular, tortuous, linear hypodensities suggesting a blood vessel. There is some color Doppler signal as well, and the image on the right shows what happens after Valsalva maneuver, and we see that there is more flow or color Doppler signal seen in these linear tubular hypodensities, suggesting a diagnosis of varicocele. This is our next patient. We have two images. These are small field of view axial T2 weighted images, and a small field of view coronal T2 weighted image in a female, showing normal appearance of the right and the left ovaries. Also seen right here, there are Nabothian cysts in the cervix, but the finding is in the uterus. Look at the abnormal contour of a small uterus, and this finding is consistent with the unicornuate uterus. Unicornuate uterus is a Mullerian duct abnormality, and it's important to recognize it on imaging, and it's frequently asked on the exams as well. The shape of the uterus is described as banana shaped. This is our next patient, and here on their chest x-ray we find this abnormal density at the cardiophrenic angle, and such densities are generally secondary to hiatal hernias, but in this case on their CT scan we see that there is herniated fat, which is at the level of the lower chest, or the aortic hiatus in the diaphragm, and here's the distal esophagus, and we find that on the coronal image there is a diaphragmatic hernia, and there is herniation of fat from the abdomen into the chest, causing that opacity on the chest x-ray. This is our next patient, and we are looking at multiple images from their CT scan of the chest. This is the image showing the lung windows, and we have a curvilinear density in the peripheral aspect of the right lung, also seen here in the sagittal image. And on this thick or MIP image, we find that density is right here. It enhances when there is contrast in the vessels, suggesting this is an arteriovenous fistula. And if you scroll up and down, you can trace a communication with either a pulmonary artery branch or a pulmonary venous branch, or both. These are important to identify and report on images. Generally, these are incidental. This is our next patient. And here we are looking at a cystic, simple appearing focus in between the liver and the stomach. And so in the gastrohepatic space, also seen right here, there is a cystic focus. And this cystic focus was further evaluated by an MRI. And here we have a T2 weighted image, fat saturated T2 weighted image. Then we have DWI and ADC images and post-contrast images showing no enhancement. And so these findings suggest that this cystic or simple appearing cystic focus in the gastrohepatic space is most likely a foregut duplication cyst. This is a common location for them, and they are generally simple in the sense that they will have a thin wall with no septations, minimal peripheral enhancement, no central enhancement. This is an interesting patient. They first had a ultrasound of the scrotum, where on the transaxial view of the left testis, we find that the testicle is enlarged and it's almost replaced by this mass of heterogeneous echogenicity. And this patient underwent a orchiectomy, and after that they had a FDG PET CT. So the MIP image from the FDG PET CT is all the way here on the right, where we see these contiguous appearing foci of increased uptake extending along the inguinal canal towards the retroperitoneal space and sort of involving the left kidney. And so in an older male, more than 70 years of age, you have to question the presence of a lymphoma as the tumor arising in the testicle, and primary testicular lymphomas are rare. And one of the characteristics of primary testicular lymphomas is there is a contiguous spread along the inguinal canal into the retroperitoneal space. And on this fused PET CT image, we find that there is a large tumor involving the left kidney, and on this contrast enhanced image we find that the tumor has grown from the retroperitoneal space into the subcapsular space of the left kidney, and here is another lymph node that is involved. So a very interesting case that we reported as a case report of a primary testicular lymphoma with direct spread. This is our next patient, a single frontal view of the chest showing perihilar vascular congestion in a batwing appearance and a very enlarged cardiac silhouette. This patient also has a malpositioned central venous catheter. Let's try to follow this right-sided internal jugular venous catheter. It comes down, but instead of going in this pattern towards the cavoatrial junction, the catheter turns towards the left and it goes through the brachiocephalic vein into the left-sided vein. And so this is a malpositioned catheter, and this should be removed and a new catheter should be placed with its tip at the cavoatrial junction. Here's our next patient, and the finding was incidental in the chest, where on this axial, coronal and sagittal images we find that there is thick apical calcification involving the myocardium, also seen here involving the anterior wall, apex, and extending partially into the inferior wall. This is almost always a result of prior myocardial infarction leading to fibrosis and calcification of the myocardium, and the distribution of this is telling us that this is in the LAD territory. Here's our next patient. They were diagnosed with breast cancer, and we find on their CT images of the chest that there is a large mass in the left breast, also seen here in the skin fold with involvement of the skin as well, some enlarged lymph nodes in the left axilla, and a nodule, a complex appearing nodule in the left lobe of the thyroid. So we performed a whole body FDG PET CT. This is their breast tumor with some internal mammary metastatic nodes, left axillary nodes, and a focus in the left supraclavicular region that was a metastatic lymph node. Here is another interesting patient who presented with abdominal pain, and their CT of the abdomen and pelvis showed multiple hypodensities around the liver. One of them is shown right here, and the same one is also shown right here in the coronal image. There were others too, and all of these densities showed an internal focus that is hyperdense inside. And compared to their prior CT scan, which is shown right here, those central foci represented or looked like these gallstones that they had previously. So what happened was, in the interim, after this prior CT scan and before the last CT scan, when they presented with abdominal pain, they had undergone a laparoscopic cholecystectomy, and the surgeons weren't able to take out all the stones, and some stones spill into the intraperitoneal compartment, and now they're spread all around the liver, causing these small abscesses. And so the diagnosis here is retained or dropped stones at cholecystectomy. This was also published as a case report. Here's our next patient. They had a colonoscopy where a polyp was seen in the rectum, and it was biopsied, and they found a rectal carcinoid. And so the patient underwent a gallium-68 dotatate scan to evaluate a rectal carcinoid. And here's the whole body image. And so this MIP image shows physiologic uptake in the pituitary, some mild uptake in the salivary glands, intense uptake in the spleen, more intense than the liver, and excretion from the kidneys into the urinary bladder. And this is their tumor. And here's the tumor on the fused PET-CT axial image, coronal image, and sagittal images. And there is no evidence of metastatic disease, which is taking up gallium-68 dotatate. This is our next patient, and we are looking at multiple images from their MRI of the pelvis focused on the prostate. So here's the prostate. There is an abnormal focus here involving the left peripheral zone. That focus shows restricted diffusion right there, and contrast enhancement. So this was diagnosed as primary prostate cancer. Patient underwent a prostatectomy along with lymph node dissection and presented with rising PSA. And at that time, we performed a PSMA PET-CT. Well, this was actually fluciclovine and not PSMA. And on this fluciclovine PET-CT, we find this focus in the pelvis right there, suggestive of local recurrence at the site of vesico-urethral anastomosis performed after prostatectomy. And the fused PET-CT image is showing here the focus of increased uptake that was reported as local recurrence at the site of prostatectomy or vesico-urethral anastomosis that was causing their rising PSA. Okay. Next, we have a patient who presented for HCC screening. They had known cirrhosis, and so we have a image of the ultrasound on the top left, which shows long axis view of the left lobe of the liver. You can see that the contour of the liver is nodular, suggesting cirrhosis. The next image in the bottom left shows that the spleen is enlarged right there, and on the right we have a focus which looks like a tumor hypodensity in the right lobe of the liver, which is solid and shows internal blood flow. And so something like this will be reported as suspicious and should be further evaluated with a multiphasic CT. And so a multiphasic CT was performed for suspected HCC. This is a non-con phase. Then we see arterial phase with uniform enhancement, and on the delayed phase there is characteristic washout. We don't see the pseudocapsule very well, but that's okay. With these findings we can make the diagnosis of hepatocellular carcinoma. And this was an LR5. Next patient was evaluated for renal artery stenosis as the cause of their refractile hypertension. Long axis view of the left kidney showing that the velocity in the left renal artery is normal. Then we have two measurements of velocity in the aorta above or superior to the kidney, and the velocity in the aorta below or inferior to the level of the kidneys. But look at the long axis view of the right kidney, where we have measured the peak systolic velocity in the proximal right renal artery. It's very high. And so what you want to do is calculate the ratio of the renal artery velocity to the aortic velocity and report a ratio. So here the ratio is very high, suggesting renal artery stenosis. Here's our next patient, and we have two views of the ultrasound of their scrotum, the long axis view and the transverse view, showing a hyperechoic focus that shows shadowing posterior to it. And this is not inside the testicle, it's outside the testicle, but it's inside the scrotum. And so something like this is benign, or most likely benign, and this is called a scrotolith or a scrotal pearl. Here is our next patient, and the interesting finding is seen on their CT of the abdomen and pelvis. On the axial image, we find some extension of this urinary bladder into the left inguinal canal. On the coronal image, we see better the extension of the bladder into the right-sided inguinal hernia, and we also see the same finding on the sagittal view, where there is fat and urinary bladder herniation into the right-sided inguinal hernia. Not very common, but once in a while we do see this, that the urinary bladder herniates into the inguinal hernia. This is our next patient. We performed a CT urogram where we acquire a non-contrast enhanced images of the abdomen and pelvis first, right here showing a tumor or a suspected tumor arising from the right wall of the urinary bladder. Generally, these tumors have some calcifications on their surfaces, so it may appear exactly like this. On the arterial phase, there is enhancement of the tumor, and on the delayed phase, when the kidneys excrete the contrast into the urinary bladder, like shown here, the tumors are seen as irregular filling defects arising from the wall of the urinary bladder and towards the lumen. So these findings are characteristic of a urothelial malignancy or a transitional cell carcinoma, generally or more commonly seen in older men with history of smoking. This is our next patient. We are looking at multiple images from their MR of the abdomen. They have this large tumor involving the right adrenal, and on the in and out of phase images, we find that there is significant signal drop from in to out of phase image. And when we see that, the diagnosis is a benign adrenal adenoma. Thank you for watching.